I'm Dr. Fakir Raveri, and this is nosocomial pneumonia in adults. The first learning objective is given a patient with hospital-acquired or ventilator-associated pneumonia, design appropriate empiric therapy. At this point, you should know that community-acquired pneumonia is relatively less severe type of pneumonia caused by less resistant pathogens such as strep pneumo, H. flu, Moraxella catarrhalis, and atypical organisms. When we look at the ventilator-associated pneumonia, it's relatively a more severe disease with mortality as high as 30%, and it's typically caused by more resistant pathogens. So the organisms that you want to target empirically are Staphylococcus aureus, which could include methicillin-susceptible Staphylococcus aureus or methicillin-resistant Staphylococcus aureus, as well as gram-negatives such as Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter species. And these organisms are usually more likely to be drug resistant. Because VAP is caused by drug resistant organism, it is extremely important to be aware of drug resistant variations. These variations in resistant patterns can occur at country level, so different countries have different patterns. Within regions, so different cities or different parts of a large city may have different patterns, as well as hospitals. Different hospitals can have different patterns of resistance. Even within a single institution or single hospital, different ICUs can have different resistant patterns. And of course, another thing that's important to know is the source of specimen. For example, if we have organisms from the urine versus organisms from the pulmonary specimen, they can have different resistant patterns. And that's why it's recommended that all hospitals regularly generate and disseminate local antibiogram, ideally one that's specific to their ICU populations if possible. And it's recommended that hospitals do this at least once a year. Now, one key recommendation from the guideline is that while we want to empirically cover for Staphylococcus aureus, if based on the local resistant patterns, it's unlikely to be, Staphylococcus aureus that's MRSA, it's probably okay to just cover for MSSA instead of MRSA. Now, in real world, I haven't really seen any physicians that would not cover MRSA in patients with VAP, but the guideline is making a point that if based on resistant patterns is unlikely to be MRSA, it's probably okay to only target MSSA. And there are some agents that cover Pseudomonas as well as MSSA. So piperacillin, tazobactam, and cefepime, for example, cover Pseudomonas as well as MSSA. And while they do not cover MRSA, if based on local resistant patterns, we think that it's unlikely to have VAP due to MRSA, it will be okay to use them. Now, who exactly needs to receive empiric coverage for MRSA? Generally speaking, both MRSA and Pseudomonas are organisms that originate from the healthcare settings. So patients who have received prior IV antibiotic in the past 3 months or 90 days need to receive one agent that has coverage for MRSA, so typically vancomycin. Also, patients with VAP who are being treated in the ICUs where the prevalence of MRSA is more than 10 to 20%, or if the prevalence of MRSA is not known, these patients need to receive one agent that is active for MRSA. Now, the same is true for Pseudomonas when it comes to IV antibiotic treatment in the past 90 days. Now, with Pseudomonas, it's recommended to use 2 agents that are active against Pseudomonas empirically. Especially in ICUs where when the susceptibility rate of Pseudomonas to the agents that we're using are less than 90%. In other words, the resistance rate is more than 10%. Or if the rate of susceptibility on the antibiogram is not available, or if the patient has a structural lung disease such as cystic fibrosis. So these patients need to receive 2 agents that are active against Pseudomonas empirically until we get susceptibility results back. Now, if we are in a ICU where the susceptibility rate for a specific agent is more than 90%, in other words, the rate of resistance is less than 10%, then a single agent is sufficient. Now, keep in mind that most anti-pseudomonal antibiotics, with the exception of delafloxacin, do not cover MRSA. So when we use two agents that are active against Pseudomonas, we typically end up adding a third agent for coverage of MRSA. So typically vancomycin. And the reason the guideline recommends two agents active against Pseudomonas for empiric therapy is that in case one of the agents doesn't cover the Pseudomonas, the other one should cover it. And this is not for every patient. These are patients that are at risk of having multi-drug resistant Pseudomonas. And of course, once a pathogen has been identified and susceptibilities are known, there is no reason to continue combination therapy. Now, your MRSA coverage antibiotics are typically vancomycin and linezolid. It's important to not use daptomycin, so you should avoid daptomycin because it's inactivated by surfactant. Now, alternatively, ceftaroline is also available should the patient be unable to take vancomycin or linezolid. But the evidence is with vancomycin and linezolid. Now, for the two agents that we use for Pseudomonas, one should be a beta-lactam, and then a second one should be a non-beta-lactam. So the beta-lactams that we choose are piperacillin tazobactam, cefepime, ceftazidime, imipenem, meropenem, or aztreonam, and non-beta-lactam would be ciprofloxacin, levofloxacin, amikacin, gentamicin, tobramycin. Now, we also have polymyxins like colistin and polymyxin B that are usually reserved as last line. So let's say if someone has received IV antibiotic in the last 90 days, so let's say somebody received ceftriaxone 2 weeks ago and now they have ventilator-associated pneumonia, we can choose an MRSA active agent like vancomycin plus one agent from beta-lactam that's active against Pseudomonas. So we can use piperacillin tazobactam, for example, and plus a second agent, so ciprofloxacin. So the patient will end up receiving three agents. So ciprofloxacin plus piperacillin tazobactam plus vancomycin. It is extremely important not to use aminoglycosides as monotherapy. So if you were to use gentamicin, for example, it has to be in combination with one of these beta-lactams. Because there has been, in the studies that we have with aminoglycoside monotherapy, the rate of mortality was higher. Now that we know how to treat ventilator-associated pneumonia, let's take a look at treatment of HAP. So for the most part, we follow the same principles. Majority of evidence is with WAP. So we have fewer studies with hospital acquired pneumonia. So majority of these recommendations are derived from WAP. So I let you, so you can see that, IV antibiotic in the past 90 days is still driving most of these recommendations. And you can see that we use the same antibiotics. So if someone has HAP and is not at risk for mortality and no risk factors for MRSA, they can receive a single one of these agents. So these agents will cover Pseudomonas as well as MSSA. Whereas if someone is at risk for MRSA, but not at risk for mortality, they can receive one of these agents for Pseudomonas, plus either vancomycin or linezolid to cover for MRSA. And of course, if someone is at high risk for mortality, then that patient should receive two agents for Pseudomonas plus one agent for vancomycin. So one of the beta-lactams plus one of the non-beta-lactams active against Pseudomonas plus an agent for MRSA. We designed appropriate empiric therapy for HAP and VAP. Now, given microbiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of like the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Now, in order to help you understand broad versus narrow, I have created a tiering system, which is by no means an official way. It's just a way of helping you understand broad versus narrow and give you a visual reference. So at the top of this pyramid, we have the narrow. So tier 1 or antibiotics such as cefazolin and trimsulfa or trimethoprim sulfamethoxazole are pretty narrow because they typically cover protease, E. coli, and Klebsiella. Again, this pyramid is strictly based on gram-negative coverage. So it is not considering gram-positive organisms, it is not considering atypical organisms, and it is not considering anaerobes. So the next tier covers protease, E. coli, Klebsiella, but also Haemophilus and Neisseria. So in tier 2, we have third generation cephalosporins such as ceftriaxone. And then the next tier adds what we refer to as CAPE. So Citrobacter, Acinetobacter, Providentia, Enterobacter, and Serratia organisms, as well as ESBL organisms. So this is ertapenem. Ertapenem is the only carbapenem that does not cover Pseudomonas. So because it does not cover Pseudomonas, it's considered the narrowest carbapenem, and I have put it in tier 3. And then in tier 4, that's when we start to get broad, because now we have coverage for Pseudomonas aeruginosa. So in tier 4, we have all the antibiotics that cover Pseudomonas. So ciprofloxacin, levofloxacin, aminoglycosides like gentamicin, tobramycin, cefepime, piperacillin, tazobactam. And then on the next tier, not only do they cover Pseudomonas, but also they cover multi-drug resistant Pseudomonas. So multi-drug resistant Pseudomonas is the type of Pseudomonas that would be resistant to tier 4 antibiotics. So that's when carbapenems come in. So meropenem, imipenem, and also ceftolozane and tazobactam, they are usually active against multi-drug resistant Pseudomonas. So they are broader than tier 4. And then now we get to the broadest tier, which is the antibiotics that actually cover CRE. So because CRE is one of the most resistant organisms, we should reserve these for CRE. So ceftazidime avibactam, meropenem vaborbactam, polymyxin B, colistin, amikacin, and plazomycin, they all have good activity against CRE, and they should be reserved. And then I also added a tier 7, which is also active against CRE, and we have tigecycline and eravacycline. And the only reason I broke tier 6 and 7 differently is just to show you that tigecycline, while it is extremely broad, it does not cover Pseudomonas. So it's actually lacking Pseudomonas and multi-drug resistant Pseudomonas, but because it's active and it's used for CRE, it's considered very broad. So, you can bundle tier 6 and 7 together, but it's important for you to understand that this tier 7 actually does not cover Pseudomonas. So when we de-escalate, if whether you are on tier 5 or 4, every time you get susceptibility results back and we can go to narrower options, we should. So that's what the guideline is recommending. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like vancomycin or linezolid for MRSA. And once the culture and susceptibility results come back, and if it is MRSA, then we continue vancomycin, and then you can discontinue the antibiotics for pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue vancomycin and start the patient on oxacillin or nafcillin or cefazolin, because these are tier 1. These are tier 1 or antibiotics. And you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lungs. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibiotics to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have an ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than piperacillin and tazobactam because it reduces mortality. So my recommendation is to, also use carbapenems for pneumonia. But basically we have limited data when it comes to pneumonia with ESBLs. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. Now let's evaluate a patient's clinical stability to determine if antibiotic therapy can be switched from IV to PO. Now, IDSA guidelines for community-acquired pneumonia gives us some guidance for switching patients from IV to PO. Now, keep in mind that community-acquired pneumonia can be treated as outpatient in, moderate or less severe patients, whereas in hospital patients, the patient will receive IV antibiotics. So, based on IDSA, patients who are hemodynamically stable and clinically improving can be, can be switched from IV to PO as long as they are able to tolerate oral therapy. Another thing to consider is to make sure that the GI tract is also functional. And we can apply some of these principles to patients with nosocomial pneumonia. Now, the reason we want to switch patients from IV to PO as soon as possible, when they can tolerate it, is, first of all, to make sure that we don't introduce any, line infections, as well as getting patients ready to be discharged. However, keep in mind that the guidelines do say that inpatient observation while receiving oral therapy is not necessary. So if the patient is ready to be discharged from the hospital and they're on IV antibiotics, and it's okay to discharge them and send them home with oral antibiotic. It's not necessarily to keep them one extra day to make sure that they tolerate the oral antibiotics. Now, there was a systematic review published in JAMA in 2016 that looked at the evidence for, criteria helping transition patients from IV to PO. So basically, absence of mental confusion, ability to take oral medications, absence of fever, hemodynamic stability, which is defined as heart rate less than 100, and of course, systolic blood pressure greater than 90. This is without using pressors. So, without using norepinephrine, the blood pressure should be greater than 90. Another criteria is respiratory rate lower than 25 and oxygen saturation higher than 90%. And of course, we have to make sure that the patient is clinically improving before we change from IV to PO. And sometimes the patient may not be improving, and there could be different reasons for it. One reason, of course, could be that we have identified the correct organism, or empirically we are targeting the right organism, but we use the inappropriate antibiotic, or we were using the wrong dose. So it's important to, target the right organisms, use the right antibiotics, and also use the right dose. So, we have to make sure that the dosing is appropriate based on body weight, based on renal function, based on hepatic function, and based on drug disease, and drug-food interaction. So as pharmacists, we have to take all of those considerations to make sure that the patient is receiving the right dose. And along with the dose also goes the right frequency. The frequency is also important. Sometimes, the organisms can develop resistance while on treatment. So it's, another thing to consider if the patient is on the right drug and on the right dose. You may want to question, whether the organism developed resistance while the patient was on the antibiotics. So sometimes we may send another culture just to make sure that the organism is still susceptible to the antibiotics we're using. I talked about the wrong dose. Sometimes the patient may miss a dose. So let's say the nurse comes to administer the antibiotic and the patient is not available. So whether the patient was sent for imaging or the patient, was not available for any reason, that's important to consider, to talk to our nurse colleagues to make sure that the antibiotics were actually administered. Another thing is to make sure that the antibiotics are actually getting to the site of infection. So sometimes, if the organism is in a specific area where antibiotics cannot get, source control becomes really important. So empyema, for example, is an example. Is when we actually need to make sure we have source control because antibiotics may not be able to get there. So it's important to actually drain the site of infection. In the case of pneumonia, sometimes the patient may still have like shortness of breath and not seem like they're getting better, and could be due to other reasons that has nothing to do with pneumonia. And of course, we have to target the right organism and use the right empiric therapy to target those organisms. And also we should think of non-infectious causes. If the patient has fever due to, either a clot or cancer, non-infectious causes of fever. Sometimes we may have drug-induced fever. So, beta-lactams, for example, occasionally cause drug fever. And lastly, presence of an unrecognized concurrent infection. So, if you're trying to target pneumonia and suddenly the patient has, bacteremia that led to endocarditis, that could be something that's, could be the reason why the patient is not doing well. And that's important to consider. Given a patient with HAP and VAP, we design appropriate empiric therapy, and given microbiological results, we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated a patient's clinical stability to determine if antibiotic could be switched from IV to PO. Now, let's recommend an appropriate duration of therapy for HAP or VAP. Now, prior to the 2016 IDSA guideline for HAP and VAP, it was usually the question of whether we should treat for 1 or 2 weeks when it comes to, VAP and HAP patients. And it was primarily due to the NUME study, which was published in JAMA in 2003, which looked at 8 days of treatment versus 15 days of treatment. And what they found was that there was actually no difference in mortality between the two groups, whether the patient received 8 days of treatment or 15 days of treatment. However, when they did subgroup analysis, in the group of patients who had VAP due to non-lactose fermenting organisms such as Pseudomonas and Acinetobacter, there was increased recurrent infection in the group of patients who received 8 days of treatment. And because of that, we started to treat patients who had VAP due to Pseudomonas or Acinetobacter for 14 days. Now, things started to heat up when a Cochrane review in 2015 compared short-term therapy to long-term therapy in patients with HAP and VAP, and found that in a group of patients who actually got short course of antibiotics for, let's say, 7 or 8 days, there was actually increased 28-day antibiotic-free days and reduced recurrent VAP due to multi-drug resistant pathogen. In other words, patients who had longer duration of therapy, they actually had more multi-drug resistant pathogens. In addition, there was no difference in mortality, recurrent pneumonia, treatment failure, or hospital length of stay when you compare the two groups. And they did still find that in group of patients who had Pseudomonas Acinetobacter, short course of antibiotics were associated with recurrent infection, but no other differences. So while these patients had the recurrent infection, those recurrent infections were less likely to be due to multi-drug resistant pathogens. So they were easy to treat. Whereas patients who had longer duration of treatment, while they were less likely to have recurrent infections, those recurrent infections were more likely to be multi-drug resistant. There was also a study published in Chest that showed that short course regimen compared to long course therapy was not associated with any difference in mortality, recurrent pneumonia, ventilator-free days, or duration of mechanical ventilation, or length of ICU. So what happened in 2016 when the IDSA guideline came out is that the panel actually did their own systematic review and meta-analysis, and they found that the specific subpopulation with VAP due to non-glucose fermenting gram-negative organism was analyzed, and no difference was observed for pneumonia recurrence. So here's what the IDSA guideline recommends for length of therapy of VAP. They actually recommend a 7-day course of antimicrobial therapy rather than a longer duration. However, this recommendation is not to replace clinical judgment. So there may be situations in which a shorter or longer duration of antibiotic may be indicated, depending on whether the patient is clinically improving or deteriorating based on radiologic and laboratory parameters. But for most patients, 7 days of antibiotics is likely sufficient. And we can extrapolate from the VAP evidence and make basically the same recommendation for patients with HAP. So also for HAP, the guideline recommends 7-day course of antimicrobial therapy, but this is not to replace clinical judgment. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated patients' clinical stability to switch from IV to PO and recommended appropriate duration of therapy for HAP and VAP. Now let's develop a patient-specific plan for prevention of pneumonia. When it comes to the prevention of pneumonia, the older 2007 IDSA guidelines has several recommendations. Of course, influenza can lead to secondary bacterial pneumonia, so influenza vaccine is recommended, as well as pneumococcal vaccine, which I will discuss shortly. Now, for patients who are hospitalized, vaccination can actually be performed at discharge prior to patients going home, and of course, it can also happen in the outpatient setting. Smoking is a risk factor for pneumonia, so smoking cessation is very important in preventing community-acquired pneumonia. And those who continue to smoke, influenza and pneumococcal vaccination is really important for them. And of course, respiratory hygiene, including washing hands, is really important in preventing spread of germs. The new 2019 IDSA guidelines did not make any new recommendations for prevention of pneumonia. Before we talk about pneumococcal vaccine, it's important to distinguish between pneumococcal disease and meningococcal disease. When we say meningococcal disease, we are talking about meningococcal meningitis specifically, and this is caused by the organism Neisseria meningitidis, which is a gram-negative coccus. Now, there are 12 serogroups, so you will see these in the meningococcal vaccine, and there are different vaccines. For example, the MenACWY has 4 serogroups here, whereas MenB only has the B. Now, when we talk about pneumococcal disease, there are 2 diseases that this may be referring to. So pneumococcal meningitis and also pneumococcal pneumonia. And this is basically caused by Streptococcus pneumoniae, which is a gram-positive coccus. And there are 91 different serotypes. Now we have 2 different pneumococcal vaccines. We have the Pneumovax 23 and we have Prevnar 13, which I will explain shortly. Now it's important to distinguish between these two because there is some misconception out there. When we talk about meningococcal disease, people may refer to this as meningitis vaccine. So it is true that by taking meningococcal vaccine, you will basically prevent meningitis due to Neisseria meningitidis. And people may refer to pneumococcal vaccine as pneumonia vaccine. This is where the misconception comes in because Streptococcus pneumonia can cause pneumonia, but it can also cause meningitis. So by giving patients pneumococcal vaccine, not only are we trying to prevent pneumonia, but also we are trying to prevent meningitis. In fact, Streptococcus pneumoniae can cause several systemic infections, including non-bacteremic, such as pneumonia, and it can also cause bacteremia, which can also lead to meningitis. So meningitis, you can see smaller portion of these cases are meningitis, but the fatality rate is much higher in meningitis compared to other diseases caused by Streptococcus pneumonia. So really, in order to prevent meningitis, you need 2 vaccines. You need meningococcal vaccine and you need pneumococcal vaccine. There are currently 4 different pneumococcal vaccine products on the market in the United States. The first one is Pneumovax 23, which is a 23-valent pneumococcal polysaccharide vaccine. And what that means is that it includes 23 serotypes of Streptococcus pneumoniae in this vaccine. It is approved for ages 2 years and older, and it is available as a 1-dose vial. So this needs to be drawn into a syringe, can be administered as an intramuscular or a subcutaneous injection, and all of these products must be stored in a refrigerator. And then, so this is PPSV, the rest of them are PCV or polysaccharide conjugate vaccine. And the first one is Prevnar 13, so this is a 13-valent and it has 13 of those serotypes. This is approved for ages 6 weeks of age and older. And all of these PCVs are available as a pre-filled syringe, so they can only be given as an intramuscular injection. Most recently, we had Vaxneuvance and Prevnar 20 approved. So Vaxneuvance is a 15-valent PCV, and Prevnar 20, as the name suggests, is a 20-valent PCV. Of note, when both of these came to the market, they were initially approved for ages 18 years or older. Most recently, Vaxneuvance got approval for ages 6 weeks and older. And I anticipate in the next few months, Prevnar 20 will also get approval from the FDA for 6 weeks of age and older. But currently, it's only available for adults 18 years or older. Let's take a look at differences between the two main different types of pneumococcal vaccines, pneumococcal polysaccharide vaccine and pneumococcal conjugate vaccine. There are different modalities of vaccines. So polysaccharide vaccines are processed as non-T lymphocyte dependent immunogens, but not immunogenic in children younger than 2 years of age. So that makes it a problem. So that's why pneumococcal polysaccharide vaccine is only available for ages 2 years and older. It's just ineffective for anyone under the age of 2. Protein vaccines, on the other hand, are processed by T lymphocytes and even in neonates induce antibodies. Because these vaccines essentially use the polysaccharides on the capsule of pneumococcal or Streptococcus pneumoniae, one strategy is to link these polysaccharides to a protein carrier, which can be processed by T lymphocytes, and this results in a more long-lasting protective antibody response, even in the very young age, under the age of 2. So that's essentially what we have done with pneumococcal conjugate vaccine. So, and because in general proteins are larger than polysaccharides, there are fewer of these serotypes that were able to fit into the vaccine. So, the polysaccharide, because these are all pure polysaccharides, there are 23 different serotypes in here. With PCV13, proteins, each one of these serotypes is linked to a protein. So only 13 of them could fit. But this is a much better vaccine because of higher immunogenicity in general, but also in young age, under the age of 2. So from 6 weeks to age 2, this will be very effective. So let's compare the efficacy. So for the pneumococcal polysaccharide vaccine is essentially effective in preventing invasive pneumococcal infection. So when we say invasive, think of meningitis. So essentially infection in the brain. And unfortunately, it does not seem to be effective in preventing pneumonia. So none of the studies that evaluated polysaccharide has not shown efficacy for preventing pneumonia. Whereas PCV, it is very effective in reducing invasive infections like meningitis, but also it has been shown to be effective in preventing non-invasive infections such as pneumonia. So historically, people had to get both of these vaccines, PCV13 first because it's very effective, and then Pneumovax 23 to supplement all those serotypes that are not included in PCV13. However, as technology has advanced, we have been able to include more serotypes in the vaccine. So with the PCV15, which came to the market in, actually both of them came to the market in 2021, we have been able to include more serotypes in the PCV vaccines. So PCV15 has 15 serotypes, and what they have shown is that they have shown non-inferiority when it comes to immunogenicity to PCV13. So all of these 13 serotypes in PCV13 are included in PCV15, and it has 2 additional serotypes. So of course it has been shown to be superior to PCV13 for those 2 unique serotypes, but also it interestingly had better response for serotype 3, which is also included in PCV13. So PCV15 immunogenically pretty good vaccine. Now these are new, so we don't have clinical data. So is it more effective as far as preventing non-invasive and invasive pneumococcal vaccine? We just don't know yet. Now the same can be said about PCV20. So it has all the 13 serotypes from PCV13, and it has 7 new serotypes in it, and it has been shown to be non-inferior to PCV13 with the 13 that are shared. And also PCV20 is targeting more of those serotypes in PPSV23 in the hopes of eliminating the need for getting PPSV23. And it has been shown to be non-inferior to those 7 serotypes that are also included in PPSV23. So here are the recommendations for receiving the pneumococcal vaccination. So in general, we can think of healthy persons with no risk factors for getting pneumococcal disease, and then of course those who have risk factors, and we'll go over what those risk factors are. So in general, for healthy individual, no risk factor, and this is in individuals who have not received pneumococcal vaccines before, because pneumococcal vaccine is also part of childhood immunization nowadays, but a lot of adults, these childhood immunization was not available at the time they were children. So for the large part, the population has not received childhood immunization for pneumococcal. But as time goes on, more and more children who receive their childhood immunization go on to be adults. So these recommendations change in time. So for those who are pneumococcal vaccine naive and are healthy with no risk factors, essentially prior to age 65, it's not recommended for them to receive pneumococcal vaccine because they are not at risk of being exposed to Streptococcus pneumoniae and develop severe disease. However, once individuals turn 65, they are at risk of developing pneumonia and meningitis and other infections due to Streptococcus pneumoniae. So it is recommended for people age 65 to receive 1 dose of PCV20, or if they want, they can get 1 dose of PCV15 instead. So it doesn't matter which one they get. So both of these are now recommended for these individuals. Now, however, because there is a gap between PCV15 and 20, it is recommended that if somebody chooses to get PCV15, they should also get a dose of PPSV23 at least 1 year later. So it's important to note that PCV and PPSV vaccines cannot and should not be administered at the same time. There should be a large time gap between them, and that is recommended to be at least 1 year. So here's what the timing looks like. So obviously if somebody gets PCV20, they're done. There is no need for them to get PPSV23. Because most of PPSV23 is covered here, and PCV in general is a better vaccine than PPSV. However, if somebody gets PCV15, they will just have to wait 1 year and then get 1 dose of PPSV23, and they are done. Now, what if somebody had already received the PPSV23 and they have not received their PCV yet? So for those individuals, again, it's recommended that as long as it's been at least 1 year after their PPSV23, then they can get either PCV15 or PCV20. It doesn't matter which one they get. They can get PCV20 if they want, and then they're done. So after this, there is no need for another PPSV23. Now, vaccine doses do not need to be repeated if they are given prior to age 65. So for whatever reason, if somebody received these vaccines prior to age 65, there's no need for them to be repeated after 65. And when PCV15 is used in those with history of PPSV23, it need not be followed by another PPSV23. And lastly, for adults who have received PCV13, which is still on the market, but not completed their recommended pneumococcal vaccine series with PPSV23, they do have the choice to get the PCV20 if PPSV23 is not available. Now, let's take a look at those with risk factors. So the risk factors, I have broken them into 3 categories. So the first category is they are immunocompetent. These are just comorbidities. And then the second group are still immunocompetent, but they have some conditions that could expose them to Streptococcus pneumoniae entering the brain and develop meningitis. So this is relatively higher risk than the first group. And then the last is immunocompromising conditions. So things like asplenia, cancer, HIV, transplant and other things on the list. So for any of these groups, the recommendation is the same. So essentially, this is, because these are high risk, we're not going to wait till they are 65. So as between the age of 19 to 64, and this is assuming that, they have not received childhood PCV vaccination, assuming childhood immunization was either not available for these individuals or it was available and they chose not to get them. So between the age of 19 to 64, it is recommended for these individuals who have any of these risk factors to receive 1 dose of PCV20, or they can choose to get 1 dose of PCV15. So it doesn't matter which PCV vaccine they get. These are very effective. It's important to prevent invasive and non-invasive pneumococcal infection in these individuals. Now, if they do choose to get PCV15, it is recommended for them to get 1 dose of PPSV23, and it is important to get it at least 1 year apart. Now, this 1 year apart becomes essentially 8 weeks for those higher risk. So if they have just comorbidity in the first group, they have to wait at least 1 year. But in the second group and the third group, because they are so high risk that you may consider to not wait for a year to give the PPSV23, you can shorten it to 8 weeks and give them PPSV23 if they got PCV15 in order to give them full coverage given their high risk conditions. Now, as before, if for whatever reason they had happened to get the PPSV23 first, then you just have to wait 1 year to give them either PCV15 or PCV20, whatever they choose. Once you give this vaccination, they're done. So once they turn 65, if they have received this, there's really no need for them to get another vaccine. Now, if they turn 65 and they had not received this vaccine, so it is recommended 1 dose of PCV, either 15 or 20, just like before, or if they had previously received PCV 13, they still need to get a PPSV 23, or they can even get PCV 20 once they turn 65. And here's a summary of what I covered in a table format, which I let you pause this video and review. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. We evaluated patients' clinical stability to determine IV to PO antibiotic switch and recommended appropriate duration of therapy. We also developed a patient-specific plan for prevention of pneumonia. Now, let's develop a patient-specific plan for prevention of influenza. Now let's take a look at the composition of influenza vaccines. Historically, influenza vaccines were either trivalent, which would include 3 strains of the flu virus, or quadrivalent, which would add a 4th strain. In the past couple of years, only quadrivalent vaccines have been available on the market. 2 of these strains cover influenza A, and the other 2 cover influenza B, one from Victoria lineage and one from Yamagata lineage. Now, for this year, the strains basically differ between the egg-based vaccines and non-egg-based vaccines, so either cell-cultured or recombinant vaccine, and I'll explain what the differences are between those vaccines. For the first strain, there is influenza A, and this H1N1 has not changed since last year. However, for the second strain, that is also influenza A, but for H3N2, the strain is different from last season, so this is new. For influenza B, the Victoria lineage has also changed since last year. The 4th strain remains the same since last year. CDC recommends routine annual seasonal influenza immunization for all persons aged 6 months or older who do not have contraindications. Now, there are no preferential recommendations for one influenza vaccine product over another, except specifically for adults aged 65 years or older, which we will cover on a later slide. Now, in general, it takes about 2 weeks on average for the body to fully respond to the vaccines and mount antibodies, so keep that in mind. And vaccination should be offered during September and October and continue through flu season while unexpired vaccine supplies last. And for non-pregnant adults, early vaccination, for example, when the vaccine becomes available in July and August, should be avoided unless there is concern that the later vaccination might not be possible. So, if somebody's in their third trimester in July, for example, they may go ahead and receive the vaccine. We'll talk more about vaccination during pregnancy on a later slide. And of course, COVID-19 vaccines can be co-administered with influenza vaccines. It's been shown both safe and effective. Now, here's a summary of the available products for this influenza vaccine season. We have one that's a live attenuated influenza vaccine, so FluMist. Historically, the live attenuated vaccine has performed poorly compared to the inactivated vaccine. So for that reason, it is only recommended for persons aged 2 years through 49, because anybody under the age of 2 or age 50 and older is at risk of complications from influenza infection. So therefore, for those people, we want the better vaccine, so the better more effective vaccines that are pretty much everything else in this table. Next, we have inactivated influenza vaccines. Now, traditionally, we have the standard dose. So this is 15 microgram shots. And we have several different formulations from different manufacturers available. Now, these are all IM injections, whereas the FluMist, the live attenuated, that's actually a nasal spray. So it's actually helpful for people who are afraid of needles. For these inactivated influenza vaccines, these are essentially all of them are quadrivalent. So when you see a number, the number 4 means that these are quadrivalent. As I mentioned earlier, we only have quadrivalent available on the market nowadays. Next, we have cell cultured. So the previous vaccine that I mentioned, they are all developed in eggs. So, essentially chicken eggs are what's used to grow these vaccines. For the non-egg based, we have the cell culture. So cell culture essentially uses mammalian cells to grow as opposed to the egg cells. We have one product, Flucelvax, so it's kind of in the name cell. So it's cell cultures, Flucelvax. And it's also quadrivalent. Pretty much these are for age 6 months and older. We also have recombinant influenza vaccine. So this actually uses recombinant biotechnology to make these in a lab. These are essentially developed in some bugs inside the lab. And FluBlock is the formulation that's available. However, keep in mind that this is only approved for age 18 years and older, so they may not be used in children. And then, specifically for elderly who typically respond less to the vaccines, we have a few formulations that boost the response. So one is adjuvanted inactivated influenza vaccine. So this uses adjuvants to increase immunogenicity. So FluAd. So ad is in the name, adjuvant. And this is for age 65 and older. And we also have the traditional inactivated influenza vaccine in higher dose. So HD is for higher dose. So instead of the 15 microgram, this would be essentially 60 microgram. So that's a higher dose. Now I will mention that the recombinant influenza vaccine also has a higher dose compared to the inactivated influenza. So instead of the 15, it uses 45 microgram, but it's still less than the high dose, which is 60 microgram. Now I mentioned these because these will be essentially these three at the bottom will have higher efficacy in elderly. So essentially everything is made through eggs except recombinant and cell culture, which brings us to the question, what if the patient has egg allergy because some of these egg proteins might be in the vaccine? Although not common, you may come across patients who have egg allergy. As I mentioned, majority of the influenza vaccine formulations are grown in eggs. Cell cultured and recombinant influenza vaccines are considered egg-free. So should we only give recombinant influenza vaccine or cell culture to patients with egg allergy? Well, first, it's important to know that CDC recommends considering patient observation for 15 minutes after administration of any vaccine, not just the flu shot. Secondly, if the patient reaction was only hives, so urticaria, they should receive any licensed and recommended influenza vaccine, including either egg-based or non-egg-based. So, it's not required to give a non-egg-based vaccine. Now, for people with symptoms other than urticaria, including angioedema, respiratory distress, lightheadedness, or recurrent MSS, or if the patient required epinephrine because of the reaction, they still may receive any licensed and recommended influenza vaccine, including egg-based vaccines. However, the CDC recommends a vaccine other than cell-cultured or recombinant should be administered in an inpatient or outpatient medical setting, so a healthcare professional can observe the patient and intervene should there be an anaphylactic reaction. Of course, if the patient received recombinant or cell culture, then monitoring in a medical setting is not required. Now, what if the patient had allergy to a previous influenza vaccine ingredients and not just egg allergy? We can consider three different groups. So one would be people with an allergy to egg-based vaccine. The second group would be people with allergy to cell-cultured vaccine. And last would be people with history of reaction to a recombinant vaccine. So in general, when the CDC says precaution when it comes to allergies, use should occur in an inpatient or outpatient medical setting under supervision of a provider who can recognize and manage a severe allergic reaction. And of course, vaccine components can be found in a package insert. So for the first group, those who have allergy to egg-based influenza vaccines, any egg-based vaccine, it's contraindicated for these patients. However, they may receive a non-egg-based vaccine, so either a cell-cultured and recombinant. Now, again, this has nothing to do with eggs. This has to do with allergy to an egg-based vaccine. Now, for the second group, who, if they had an allergy to a cell-cultured inactivated influenza vaccine, any egg-based is contraindicated as well as the cell culture vaccine. However, they may receive, cautiously a recombinant influenza vaccine. And of course, last group, if they had a history of allergy to recombinant, again, egg-based is contraindicated as well as recombinant influenza vaccine, but they may cautiously receive cell-cultured influenza vaccine. And of course, if it is unknown which influenza vaccine they had a reaction to, then an allergist can be consulted to figure out if it's okay for the patient to receive a vaccine. Now, what are vaccine considerations during pregnancy? So persons who are pregnant or postpartum should receive any inactivated influenza vaccine or recombinant influenza vaccine, as long as this is before or during the flu season, and can be given before pregnancy and during all trimesters of pregnancy, but in general, limited data during the first trimester. The live attenuated vaccine should not be used. It's actually contraindicated during pregnancy. And in general, there is less experience with more recently licensed inactivated influenza vaccines, such as all the quadrivalents that are available on the market and the cell cultured based vaccine. And there is limited data with recombinant influenza vaccine. Now, for immunocompromised patients, the same recommendation is made. So either inactivated influenza vaccine or the recombinant, and of course, inactivated either egg-based or cell-cultured, similar to pregnancy, and live attenuated should not be used. So the live attenuated, because they replicate in the body, they should not be used immunocompromised, because it can replicate and get out of control due to immunocompromise. Last, what if the patient is taking influenza antiviral medications? Now, administration of inactivated or recombinant is not affected by antiviral agents. However, if somebody is to take the live attenuated, because that vaccine needs to replicate in the body, antiviral medications will affect the vaccine efficacy. And when it comes to our antiviral agents used for the flu, the half-life makes a difference. So, some of these, such as Pramivir and Baloxavir, have much longer half-life. Whereas oseltamivir and zanamivir have shorter half-life. So in general, the live attenuated influenza vaccine will have reduced effectiveness if oseltamivir is taken within 2 days before and up to 14 days after. So in other words, if somebody is taking oseltamivir for an actual infection or for either prophylaxis or whatever reason, and they are to receive a live attenuated, they should wait 2 days after discontinuing oseltamivir to start vaccination. And then once vaccination is given, they should wait at least 14 days before they can receive, for whatever indication, another dose of oseltamivir. And the same concept applies to Pramivir and Baloxavir, but the timing is different. So for Pramivir, 5 days before and up to 14 days after. The 14 days is because it takes, on average 2 weeks for the vaccine to kick in. So once it's given, regardless of which one it is, you want to wait 14 days for the vaccine to replicate and mount a response. And then the other ones, the 2 days, 5 days, and 17 days, you essentially waiting for these drugs to be cleared from the body based on the half-life, and then give the vaccination. Now, what if the patient is elderly, and that's defined as age 65 years or older? So there are 3 preferential recommendations. So either the high-dose inactivated influenza vaccine or the recombinant influenza vaccine, which essentially has a higher dose than the standard dose inactivated influenza vaccine, or an adjuvanted inactivated influenza vaccine. And of course, they do say that if none of these are available in the pharmacy, then any other age-appropriate influenza vaccine should be used. So any vaccine is better than no vaccine. So you don't want, in other words, if somebody's at the pharmacy and these 3 are not available, you do not want to, order it and have the patient come back, because there is a good chance that they may not come back. So any opportunity to vaccinate individuals is very important, because any vaccination is better than no vaccination. And the reason these 3 are preferred over others is that, for one, the high dose was studied against the standard dose, and these are specifically in the trivalent vaccines, where they did a randomized controlled trial, and they found that the high dose was superior to the standard dose. Specifically, it had about 24% greater relative efficacy compared to the standard dose. And when it comes to recombinant compared to the standard dose, again, recombinant has a slightly higher dose in it. So in elderly, they also saw higher efficacy, so about 30% greater relative efficacy compared to the standard dose. And of course, the adjuvanted Fluad uses MF59 as an adjuvant to increase immunogenicity, which showed about 63% greater relative efficacy. This concludes this presentation.